Okay, welcome everybody. It is 3 o'clock, so I think we'll go ahead and get started, being respectful of everyone's time. I want to welcome you to today's PrEP webinar, that is the Psychiatric Rehabilitation Educational Program. And today's topic is cognitive behavioral therapy for the treatment of criminogenic thinking and behavior. Our presenter today is Dr. Anna Rehwinkel, did I say that correctly? Morfe, a psychologist with Trenton Psychiatric Hospital. And we think that you'll really enjoy this. We have a lot of participants signed up, and so we're really excited about what today brings. So we want to welcome you and to, just reiterate that it's an interactive training. We encourage you to ask questions and participate throughout the training. We will try to delay a lot of the discussion to the end of the presentation, so Dr. Morfe can present a lot, the bulk of her materials. There's a lot to present. A recording of this webinar will be available after the presentation on the Rutgers SHPRI website, and we will drop that link in the chat box for you for ease of reference. A few disclaimers. The PrEP is an online forum for a variety of topics that are relevant to state psychiatric hospital staff in multiple disciplines. So while Rutgers and DBHS are co-sponsors of this program, the PrEP webinars are peer presented, and as such, content is independently developed by the presenters each month. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. I also want to let everybody know that this session is being recorded, so please be mindful of that. And again, it will be available for you at a later time for viewing. Today's presenter is Dr. Morfe, who received her undergraduate degree in psychology from Johns Hopkins University, a master's in PsyD and clinical psychology from LaSalle University, and participated in the Ruth L. Kirchstein National Research Service Award Fellowship in primary care research at Robert Wood Johnson Medical School, Rutgers Medical School. Dr. Morfe previously worked for the Federal Bureau of Prisons and graduated from the Federal Law Enforcement Training Center in Glencoe, Georgia. She is a triple licensed clinical psychologist working employed full-time at Trenton Psychiatric Hospital, where she works in admissions and supervises the pre-doctoral psychology interns. And Dr. Morfe is a proud member of the New Jersey Suicide Prevention Committee. So please, let's welcome Dr. Morfe. And with that, I'm going to turn this over to her.
Okay, so I'm just going to request control of the screen. Okay. So I just want to start by saying thank you for having me here today. It's such an honor to be able to speak to this audience about a topic that is very important, especially relating to the patients that we work with within the state psychiatric hospital system. As I told Dawn, I had a blast making this, and I think it also showed to me how rusty I am with my PowerPoint presentation skills. So I just want to get ahead of this and say that I had footers for all of my slides, and I then realized I applied I pasted something into my footers, which wiped out my footers. So the references are in the back, but if anyone has any questions specific to any one slide, feel free to contact me at the end of the presentation. I can give you a little bit more direction on where any information came from. So today we're talking about criminogenic thinking or criminal thinking, and how we can address such thinking with cognitive behavioral therapy. Oftentimes, that word criminal, it has a lot of stimulus value. So what I wanted to do is just have people answer in a poll this question to help people understand a little bit that, we all engage in some element of kind of permission giving in order to get our needs met that may be violating of social norms or laws. So if you could just please respond. Okay, so are the results being shared?
Yes, I'm sharing them. Can you
Okay.
see?
Yes, I can see.
Okay.
Yeah. Right. So it looks like all but one person, I'm imagining that person does not drive, has driven over the speed limit. So thank you. And I'm hoping that responding to that question was a little bit humbling, so that you can see that, the concept of, criminal thinking is not something, for the lifestyle criminal, right? All people have the propensity or the ability to potentially engage in thinking, that can cause us to make choices that can have consequences that could get in the way of us living in line with our values or achieving the goals that we may have for ourselves. How do I close? Let me close that. So what we're going to be talking about today is just an introduction to criminal thinking and criminal lifestyle theory. I will also go over the basics of REBT, which most people probably are aware of. But if not, I will just explain some of the basics of REBT, which is one of the first forms of cognitive behavioral therapy. I will also go over an intervention from REBT called rational self-analysis and explain how that intervention can be used in individual and group contexts. So as Dawn explained, I've worked in prison settings and I now work in a Trenton psychiatric hospital. So I can say that, I don't know why this is moving, that working with the forensic population can be difficult. Okay, it can be really difficult. It's important for everyone who works in a forensic context to kind of be self-compassionate, and to understand that, this is a field of work that can easily lead to burnout. Oftentimes we're working with individuals who have perpetrated offenses against others. And the work that we do is perpetrator focused. And in doing so, especially, if you are actively, just talking or processing about any kind of victimization that a person perpetrated, or if you're reviewing discovery, it easily can, cause you to have certain reactions, and also can contribute to compassion fatigue. And it's just really important that if you are working in the forensic realm, that you really be aware of that, because, when working with, patients that cause, such burnout, it could cause an impact in clinical judgment. One of the other issues that is somewhat problematic, or can be difficult when working with a forensic population, is that the goals of treatment are often changes in behavior rather than just a decrease in symptoms. When we're working, if we're treating someone specifically for anxiety or depression, we're able to monitor symptoms and see that, with our intervention, there is a decrease in symptoms and maybe an overall improvement with quality of life. But when we're working with people to, change their, general kind of like schema, in hopes of changing the way that they behave, it's a lot looser, and it's a lot more difficult to do. Also, if we are working specifically, to decrease the risk of, reoffending in any kind of way with whatever population we're working with, treatment failure means suboptimal outcomes, and could also, result in potential re-victimization. For that reason, it's really important to find clinicians who have knowledge, have skills, and who are actively, diligent in their appraisal of, what our best practice is when it comes to working with patients within the forensic environment. I'm just going to take a pause here because, Dawn, for some reason, my screen is showing like a kind of like a pixelated slide, and I'm not able to advance when I'm clicking the button.
Dawn, can you see that?
Okay. All right. Hopefully all goes well from here. So I just want to kind of give some definitions as we're moving forward. What I'm going to talk about today, is one particular intervention that can be provided to individuals within either a prison or forensic hospital or a psychiatric hospital setting to potentially, decrease any kind of criminogenic behavior. What we are here to talk about is specifically that. We're not here to talk about necessarily, the criminalization of the mentally ill or substance use. I certainly will acknowledge, racial disparities and things that are, within our criminal justice system. Those are things that certainly need to be discussed, but is outside of the scope of this presentation. I also will be using two terms. So when I'm speaking about maybe research on persons who are justice involved, who were, researched within a correctional setting, I will refer to those individuals as offenders. If I'm talking about people, who have a history of violence or criminal behavior either before our hospitalization or within the hospital setting, I will be talking about patients. So you'll hear me use those terms offender and patient interchangeably. So what we know when providing cognitive behavioral treatment to, decrease the risk of recidivism as it pertains to criminal behavior is that using a risk-need-responsivity model is really best practice. So two Canadian psychologists, I believe they were psychologists, they put forward this model, and it has, been researched and demonstrated to have good effects. So the risk stands for an offender's risk level, with the idea that offenders' risk should match the level of service that they receive. For example, high-risk offenders should receive more intensive treatment, monitoring and supervision than low-risk offenders. Need is the need principle, which asserts that when dynamic risk factors are changed, which we'll go over, there is a subsequent decrease in the likelihood of further criminal behavior. There are needs that are considered criminogenic, and there are needs that are considered non-criminogenic. Mental health symptoms are considered less criminogenic or non-criminogenic, but are also recommended to be addressed co-occurring while you're addressing any criminogenic behavior. Responsivity asserts that clinician and staff style and mode of intervention should be matched to special offender characteristics. These characteristics include motivation, intelligence, communication barriers, cultural or ethnicity issues, interpersonal anxiety, learning disabilities, or brain injuries, or whether or not the person that you're dealing with is actually motivated to be engaged in treatment. SAMHSA has something called the Gains Center, and there's a link at the end of my slide deck that has a really nice flow chart. So it kind of helps you understand, when you're working with a certain population and you're trying to determine, what really is the risk or what is the need or what should the responsivity be, you can use this flow chart to help guide you. As I said before, empirical support exists for this conceptual model. And I think that I read in one study that I think when R&R is used, it decreases offender recidivism by up to 35%. So the R&R model came after many, many years of research, where people were trying to figure out, what works within the offender population. And Mortensen in 1974 determined that really nothing that people were doing prior to, true rehabilitation, using cognitive behavioral efforts was really moving the needle. Additionally, kind of using that get tough on crime model was really expensive. So Andrews and Bonta put out this risk-need-responsivity model and have identified the criminogenic needs that can be addressed within the context of a therapeutic setting. So some of those criminogenic needs or risk factors are history of antisocial behavior, antisocial personality, pro-criminal attitudes, or also called antisocial cognition or criminal thinking. I will continue to use the language of criminal thinking over the course of this talk, just because it's easiest for me. pro-criminal associates, family, marital issues, schoolwork, leisure recreation, and substance abuse. Some of the criminogenic needs are things like self-esteem, emotional discomfort, such as anxiety, major mental disorders, schizophrenia, such as schizophrenia, depression, lack of ambition, lack of physical activity. Andrews and Bonta identified that these are the criminogenic needs or risks that should be addressed in treatment in order to decrease recidivism. They further identified the big four, or the primary four criminal risk variables, which are antisocial cognition, antisocial associates, and antisocial personality, which are considered dynamic variables, coupled with antisocial behavior or history of criminal activity. The rest are considered the central eight. So what is antisocial cognition or criminal thinking? Glenn Walters, who is a professor at Kutztown University, was a former psychologist within the Federal Bureau of Prisons, and he's done, some of the most work as it pertains to this concept of antisocial cognition, or what he has made popular by calling criminal thinking. And his definition is that criminal thinking is the beliefs, attitudes, and values of a person that are supportive of criminal behavior. Or antisocial cognitions or antisocial thought patterns, pro-criminal attitudes, and criminal thinking reinforce participation in criminal activity. It's important to note that, criminal thinking encompasses both content, like what a person is thinking, and also the process of how an offender thinks. And within treatment, those are two things that you will need to address, both the process and the content. So this concept of criminal thinking, has been studied for many years. And I just want to give a little bit of background on Glenn Walters' ideas behind criminal thinking. So it evolved from previous research. First, Sykes and Matza in 1957 came out with this idea of theory of neutralization. Gresham Sykes was an American sociologist and criminologist who actually taught at Princeton University and studied at New Jersey State Prison. He put forward some of the first literature that showed that there are a lot of issues faced by corrections officers and inmates. And David Matza was an American sociologist. So the theory of neutralization tried to explain how offenders dealt with feelings of guilt after violating some kind of values. They put forward this assumption that people are always aware of moral obligations, and that offenders use cognitive mechanisms to neutralize or eliminate guilt. As a result of their research, they came forward with 5 neutralization techniques: denial of responsibility, denial of injury, denial of victims, appeal to higher loyalties, and condemnation of condemners. Research was not very supportive of their theory. Later, Samuel Yokelson, a psychiatrist at St. Elizabeth's, and Stan Same now also at St. Elizabeth, but in the role of psychologist, they researched people who had a history of criminal activity. Their sample set, though, was not generalizable because they did a lot of work with people that were found not guilty by reason of insanity. They also came up with way too many ideas or, thinking errors to explain why people go on to, commit crimes. They put forward 52 thinking errors, and their theories were really based more on emotions, things like fear, anger, pride, fear of fear, or behaviors, the longer, sexuality, lying, lack of interest in responsible performance, rather than the cognitive. But really, I think some of the most criticism came as a result of the fact that, there were 52 thinking errors, and their population really was not representative of most people who engage in any kind of rule-breaking behavior. So Glenn Walters and So Glenn Walters and his associate, I forget his first name, who is also a psychologist in the Federal Bureau of Prison, they came up with the criminal lifestyle theory. So the criminal lifestyle theory put forward that criminal lifestyle is really more of an idiographic thing, that people are making individual level decisions to be involved in criminal activity. Really what they were saying is that when people are breaking rules, they're working or activating some kind of decision-making model that they have developed over the course of their lifetime. They used 4 major theories: rational choice theory, routine activity theory, differential opportunity theory, and developmental theories of risk-taking and moral development to create their theory. In their theory, there are 2 different types of criminal thinking. There is proactive, and then there's reactive. Reactive criminal thinking is the impulsive, reckless, and irresponsible nature of criminal thinking that disrupts decision-making via the hedonistic belief system. This idea that people do things for one of 2 reasons: to avoid any kind of pain or to seek pleasure. Also, that people also engage in this concept of temporal discounting. That an individual's tendency to perceive a desired result in the future, they see it as less valuable in the moment in order to seek that kind of pleasure. We see a lot of similar concepts used in violence research, when you think of reactive versus instrumental violence. There's also proactive criminal thinking, which is more of a cold and calculated type of thinking, which interferes with effective decision-making by neutralizing or reducing moral emotions. So you see how there's somehow this evolution where Glenn Walters used some of the ideas behind Sykes and Matza of neutralization theory, and he incorporated it into the criminal lifestyle theory. And the idea is that once moral emotions are eliminated or reduced, a person is left with the utilitarian decision to commit or not commit a crime, unfettered by any emotional constraints. So one type of criminal thinking amplifies, and the other type of criminal thinking can dampen emotions, but both can be damaging. So when we're dealing with people who tend to have both proactive and reactive types of criminal thinking, we're trying to kind of disrupt both things and encourage people to take more of a rational approach, which we'll get to when we talk about REBT. So I already explained most of this, that Glenn Walters came up with the criminal lifestyle theory. And within the criminal lifestyle theory, there is the reactive and proactive types of criminal thinking. So what makes up the proactive and reactive types of criminal thinking are 8 specific thinking styles. And when we're working with people who have a history of breaking rules or laws, at least in my experience, we like to really focus on these 8 styles of criminal thinking, because it's important to help people understand, what kind of process they are more likely to engage in. And then from there, they can be more aware of any kind of content or specific kind of semantics that they may have running through their mind, that would be promoting of any kind of rule-breaking behavior. So the idea is that crime is based, at least in part, on belief systems. And in Glenn Walters' work, he created something called the PICTS, which we'll talk about at the end of the presentation, which is an 80-item self-report measure that you can have people fill out, and it will assess for the various types of thought processes that may make them more likely to engage in some kind of criminal behavior. If my friends from graduate school were here right now, they'd probably make fun of me because I always somehow incorporate this picture, Yuri Bronfenbrenner's ecological model, into any presentation that I give. It's really just important to highlight that any person that we're working with, as most of you know, is developed in a context. And that is outside of the presentation that I'm giving today. But it is really important to understand, that life experience, especially over and over again, forms the beliefs about self, world, causes perceptions to become more automatic and inflexible. And when we're working with individuals in a forensic setting, if we really are trying to target criminal thinking, it is very important to understand the social ecological influences in any person's life and how that, came to form maybe some of the processes and content that a person is presenting with. But, with the theory of addressing criminal thinking particularly, the idea is that, yes, there is context, there is social learning, things have happened to all of us, right? But at the end of the day, regardless of the social and economic influences, individuals who engage in any kind of criminal activity or criminal lifestyle are rational actors. And through that, belief, right, or that theory, that allows for a sense of hope, right, and a sense of intervention. Okay, so we're going to go through individually the 8 styles of criminal thinking. So there's mollification, entitlement, power orientation, super optimism, which are considered more proactive forms of criminal thinking. And then there's cutoff, cognitive indolence, and discontinuity, which are considered reactive. Sentimentality actually is considered to be apart from both, but really, I think, in my personal opinion, seems to be more of a proactive type of thinking error. So the first is mollification. Mollification is the thinking style that repeat offenders, seek to play down the seriousness of past criminal conduct and current interpersonal conflicts by blaming problems on external circumstances, making excuses for their behavior and pointing out unfairness in the world or devaluing their victims. So in this slide and the next 7 slides, you'll see there's a little bubble of an example of, maybe what someone would say. On the left, you're seeing the process, and in the bubble, you're seeing the actual content of a person's thinking, that could be labeled as that thinking error. I think we missed one. Nope. Okay, the next is entitlement. A person who has a tendency, to engage in criminal behavior believes that he or she is entitled to violate the laws of society and the rights of others by way of an expressed attitude of ownership, such as it's mine, or a sense of privilege, I'm above the law, or by labeling wants as needs. I need a new car, I need expensive clothing, I need a trip to Las Vegas, etc. Power orientation. Power orientation is a style of thinking where one chooses power and external control over self-discipline and internal control. People who are repeat offenders attempt to exert power and control over others. Consequently, they feel weak and helpless when they're not in control of a situation, and they attempt to alleviate this feeling by manipulating or physically assaulting others. Super optimism. This criminal thinking error is seen when people tend to get away with their crimes. When people have growing success, when they violate and they don't get caught, it creates a growing sense of overconfidence in which a person may believe that they are invulnerable, indomitable, and unbeatable. Ironically, this belief leads to their eventual downfall. and cutoff. This is probably, in my experience, one that I have seen most commonly. Something that I missed in the beginning of the presentation, and I apologize, is that, when I worked in the Federal Bureau of Prisons and we ran this similar group, it was taken from a larger therapeutic community program that was targeted to address substance use. And oftentimes these programs, any kind of cognitive behavioral intervention for criminogenic thinking, is provided, in the context or co-occurring with some kind of substance abuse treatment, because there are a lot of overlapping etiologies. So with cutoff, with practice, a person eliminates normal feelings which deter criminal action through a simple phrase like just chill, screw it, or you can fill in the blank. They may think of an image, maybe something from a movie. They may think about or play, certain music that kind of pumps them up. In some cases, the person may use drugs or alcohol to cut off fear or anxiety, guilt, or other common deterrents to criminal activity. The next thinking error is cognitive indolence or lazy thinking. Lazy thinking permits taking shortcuts, which inevitably leads to failure, low self-evaluation, and poor critical reasoning skills. Discontinuity. People who habitually break rules or laws may have difficulty maintaining focus over time because of being easily influenced by events and situations occurring around them. As a result, they have difficulty following through on initially good intentions. The last thinking error is sentimentality. Like most people, the repeat offender has an interest in being viewed as a nice person. However, this creates a serious dilemma, given the level of interpersonally intrusive activity that they may have engaged in. Consequently, they may perform various good deeds with the intent of cultivating some kind of Robin Hood-like image or wanting to be considered as kind of one heck of a guy or girl. So we have the fact that their criminal thinking encompasses both content, what a person thinks, and the process, how a person thinks. And there's this idea that these two things, both the content and the process, are somehow flawed, and that these flaws are causing disruptions in effective problem solving. So I'm just giving you a visual, of what effective problem solving, is classically considered to be. You define a problem, you generate alternative solutions, you evaluate alternative solutions, you select and implement a solution, and you assess the outcome. So for us, if we are working with people whose problem solving has somehow created victims, has somehow, been self-defeating or problematic for them in living in line with their values or achieving whatever goals that they may have, that we need to disrupt their problem solving and somehow give them an alternative way to solve problems. So we can do that in many different ways. At the end, I'm going to show you a bunch of resources that speak to how you can use various cognitive behavioral interventions to target criminal thinking. But I'm just giving you this one that I personally have used in my own clinical experience. So we used REBT in the past, and some of my colleagues at Trenton Psychiatric Hospital are also using this currently. So REBT was started by Albert Ellis, who previously was trained and practiced in psychoanalysis. He was interested in philosophy, and he developed his own psychotherapeutic theory, first called rational therapy, around 1955. Around the same time, there was this person named Aaron Beck. I'm not sure if any of you have ever heard of him, but he was also creating his version of cognitive therapy. Ellis, though, first presented the ABC model of emotional disturbance. He had this idea, that when people experience, any kind of emotional disturbance, it's the result of their perception of their reality, which would be A, or the adversity, and B, their belief system. So there is, A is whatever thing that they're encountering. B is the belief system or their perception of that reality. And C is the consequence. If we're experiencing any kind of negative affect, then, there's a good chance, that our belief system has a lot to do with it. You'll see this in a lot of Albert Ellis books. This is a quote from Epictetus, who was a Greek philosopher, who generally believed that events are always like outside of control of men, and that we should accept whatever happens calmly and dispassionately. However, individuals are responsible for their actions, which they can examine and control with self-discipline, right? So, for those of us who, work from an ACT framework or have done anything related to AA, this is kind of where the idea of, control what you can and accept what you cannot has come from. Okay. So in REBT, there is basically this idea that if you have irrational beliefs, it will lead to or could lead to dysfunctional behavior. And if you have rational beliefs, it could lead to adaptive behavior. So the way that we can help the people that we work with increase the likelihood of thinking rationally is through an intervention called rational self-analysis. So here I'm giving you a PowerPoint version, but I did speak to the publisher of a form that we use at Trenton Psychiatric Hospital and that we used in the Federal Bureau of Prisons. Here's this form from the Change Companies, which I was told I was able to show. I left a link at the end of the presentation so you can look at it. But basically, when we're working with individuals who we're trying to target, their criminal thinking, we'll give them this form, and on it we'll show two columns. One is the irrational approach, and one is the rational approach. So you will ask someone to explain what happened. Okay, that would be the activating event. And not only what happened, what were your beliefs? What was your appraisal of the situation? As a result of what happened, as a result of your beliefs or your perception of reality, how did that make you feel and what did you do? You then go through the rational approach. And in doing so, you ask people to do what's called a camera check. If there were a camera on the wall and it were videotaping what you just explained to me, what would it have seen? This prompts people to give you more of an objective account of reality. From there, you would encourage people to think about that camera check. If you were to actually have, perceived reality in that way, how would that maybe change your belief system? And before even doing that, you want to ask people to stop and think. Ask themselves what are considered these 5 rules of rational thinking. Are your thoughts based on objective reality or facts? And that's what the camera check helps you with. Are your thoughts helping to protect your life and health? Are your thoughts helping you to achieve both your short and long-term goals? And are your thoughts helping to keep you out of conflict with others? Last, are your thoughts leading you to feel the way you want to feel without substance use, criminal lifestyle activities, or other harmful or self-defeating behaviors? The rule of thumb that I was always given is that if a person says no, right, to at least 2 of these things, that there's a good chance that there's room for improvement or room for a rational challenge. So from there, you would ask people to, take an alternative viewpoint. If they were to have perceived their reality through the lens of that camera, what would their belief system have been? What would their perceptions have been? And as a result, would it have changed how they were feeling? Would it have changed how they were acting? So up until this point, I've just been giving you kind of the ingredients of a cognitive behavioral intervention to address criminal thinking. Now, I've talked about the criminal lifestyle theory, the criminal thinking errors, and that one potential way to help people catch themselves if they are thinking in a way that is irrational or possibly problematic. You can put all of this together in either an individual or a group setting. I'm just going to give you an example of like structure based on my experience. So when I was running this group, it was a 12-week group. We would have 8 to 12 individuals. Oftentimes we were recruiting across a compound, but within the prison, asking unit counselors for people within their unit that maybe were engaging in problematic behavior. Or maybe we were trying to target people who had the most infractions and had to be sent to the special housing unit for one reason or another. And that really goes to the risk model, right? We were trying to get the people that were most likely to reoffend to attend this group. We would then bring those people into a meeting prior to the beginning of the group, and we would engage in some kind of motivational interviewing, a review of the group rules, and try to assess for stage of change to determine if that person, is going to be a good fit for the group. In our hospital setting, you would have to come up with your own inclusion or exclusion criteria, which I will get to, once I go over this. Once you have your group, and again, this was pre-COVID, so this was 8 to 12 people, you would use the first 3 sessions to review the group rules, explain how to use the RSAs. We also used a workbook from the change companies, which I guess I can't show just because my screen is blurred, but it's a nice colorful workbook that we are using right now at Trenton Psychiatric Hospital that explains the basics of how to do an RSA. I've even seen people incorporate kind of some really foundational biobases education, like how the brain works, the centers for, emotion, the centers for, thinking and logic and things like that. From there, after the first 3 sessions or so, we would then review one thinking error every week. So we would provide education on the thinking error and then encourage people to complete homework between sessions, ask individuals to complete an RSA. And then with the next session, we would review people's homework and then keep going with educating about the next thinking error. Homework is really, really important. The change companies really believes in this concept of interactive journaling, and research supports that when people are repeatedly go over a concept and they write it down, it becomes more ingrained in their way of thinking. And hopefully that results in different outcome when it comes to behavior. When I work with individuals, I always say that my goal is to help you become essentially your own mini psychologist. You're not always going to have a therapist there. You're not always going to have an RSA in your hand to work through. So the idea is that with repetition and mastery, you'll be able to utilize the skill on your own if and when you are in a situation, so you can check yourself and be a little bit more aware if and when your thought process is going to make you maybe more vulnerable to engaging in behavior that's problematic, that could result in breaking any rules or laws. And then the last session is used for a review and a debrief. So this is the format that was used in a very large institution where the psychologist to inmate ratio was not favorable at all. In the psychiatric hospital systems, the ratio is way more favorable. So research really supports using more of at least 15-week model if you are going to use cognitive behavioral therapy to address criminal thinking errors, and to meet more than once a week, to meet 2 to 4 times a week, to really, again, create that mastery, and to ensure that all people participating are are grasping the concepts. So some recommendations for inclusion and exclusion criteria. You would want to determine a certain reading level. I mean, there's not a lot of reading and writing involved in the group, but it's important that the persons that you're working with are able to grasp the concepts and able to really do the homework between session. You also need to determine if the individuals participating in the group are safe to be in a group setting. And ideally, they would be demonstrating some willingness and ability to participate. Within the state psychiatric hospital system, this is just my idea, and I would be curious to hear anyone else's idea. You may want to review things like nursing logs or the ERMS databases to find individuals with the highest incidence so that you can target who really is at highest risk. You then from there, can form your group. Now that we have, I guess, different resources as a result of COVID, through the use of telehealth, you may even be able to create a group across a hospital, right, across complexes or buildings, so that you can get together people who may be, some of like the heaviest hitters or the people that tend to, have the most incidents either prior or while being in the hospital. Okay, so again, this is just a basic structure, but a lot of the literature and resources that are out there for using CBT in a forensic setting give like some licensure to what is feasible within your setting. But there's a great book called CBT in Forensics, or Forensic CBT, by Raymond Chip Tefrate and Damon Mitchell. And in there, they give some intervention principles that I think are really important. And if you are to adhere to that and these like basic, well-researched principles, you're probably going to be providing, a decent intervention. So the first principle is need for simplicity. Research indicates that higher risk offenders typically have lower levels of functioning. The second is stress the common. You're likely working with a heterogeneous group, so the more basic the content, the more offenders or patients are going to connect with the material. You also want to use fewer learning ideas. The goal is to develop few competencies that change thinking over time to impact behavior over the long term. Parsimony, stressing the common, and using few learning ideas assists with the generalizability and transporting of what is experienced and learned in the intervention to other contexts in their lives. You also want to start positive. You want to try examining positive thinking patterns and how positive thinking patterns is connected to positive behaviors. I was an athlete. I wish I could say I still was, but I love to use sports analogies. Think about times where maybe you were about to make a free throw, right? Or, do whatever. And you engaged in, positive self-talk, right? And what happened? How did that help you in terms of your performance? And the last principle is discuss assessment results. So something that we haven't really talked about, which is so important, is that there are a variety of criminal thinking assessments. And you can use these assessments pre-treatment to see where someone is in terms of, the intensity and kind of ubiquitous, nature of their thinking, other thinking. And then you may want to use that as a tool, in terms of, insight orientation, or if you are in need of using some kind of motivational interviewing to move people along the stages of change. You can also use assessment results after treatment to help people understand, where there was movement and any recommendations for future treatment. I have to say, with this specific group, this criminal thinking group, and the format that I'm giving, I'm waiting that people are going to ask, what is the research to indicate that this is evidence-based? Using the specific, Bureau of Prisons outcome data, that's not really there, right? But we do know that, using cognitive behavioral interventions to target criminal thinking is effective. And there have been systemic reviews and lit reviews that have indicated, that there is usually about like a 25% decrease in recidivism. So whenever you're asking someone to change behavior, especially if you are asking someone to change behavior when it really wasn't their idea to do so, you're likely going to get either ambivalence or resistance. So as a result, naturally, you have to be prepared to utilize motivational interviewing. As I said before, one of my favorite quotes that pertains to motivational interviewing is by mathematician Blaise Pascal. We are usually convinced more easily by reasons we have found ourselves than by those which have occurred to others. So, through the use of motivational interviewing, we can help the individuals that we're working with start to kind of advocate for change. And when you do that, when you kind of capture people who are really in a place where they are ready to act and they are ready to incorporate alternative ways of solving their problems and alternative ways of behaving, that's when you are going to get the best outcome. Additionally, as you saw in the RSA, it asks that question, is your way of thinking helping you to achieve your short and long-term goals? It's very important that, in the context of your work, that there is some kind of framework, right, that someone can work from. I'm giving two examples here. There's the Good Lives model, which really helps people understand, what behavior are you trying to leave behind? What behavior are you trying to move toward? Or there's acceptance and commitment therapy concepts, that really can be incorporated into any kind of values clarification group that could also be co-occurring within a hospital setting or in an institutional setting. These things can also be used at the outset of treatment. In a hospital setting, if you're going to have a captured audience for a longer period of time, and the ratio of psychologist to or clinician to patient is more favorable, you probably have more bandwidth to be able to work really individually to help people to clarify their values. Or within the state hospital system, you can go back to the treatment plan. It's one of the first questions that we ask people upon admission is, what do you want to work on? What is it that you're hoping to achieve both now and in the future? And you can use that as kind of your guiding principle. And sadly, what we know is that a lot of these interventions that are provided, at least in correctional settings, they fail because there's a failure in aftercare or follow-up. I think one thing I can say that the federal prison system does well is that there really is an attempt to kind of weave these concepts across points of contact. People with an education are aware of criminal thinking errors and RSAs. Bosses on the job site are probably aware of criminal thinking errors and RSAs. Certainly, it's at the core of the substance use treatment. So, when you're interacting, with people, in other realms that can speak to or can inform those dynamic criminogenic needs, it's important that, or it would be ideal, that this intervention somehow be there, or at least the knowledge be there, so that the professional that is working with the offender or the patient, be able to really integrate and empower the person to utilize these alternative ways of thinking, alternative ways of coping. And in an ideal world, we would also see that in aftercare programs and case management, maybe probation, maybe through IOC, maybe even through the cruel courts. So this is like a way bigger discussion than for today, but these are just some of the assessments that can be used to assess for the presence of criminal thinking errors. Based on the 8 criminal thinking errors that I went over today, the Psychological Inventory of Criminal Thinking, or the PICTS, is the one that really is structured and designed to be sensitive to those thinking errors. Within the hospital system right now, at least at TPH, we are using the MOTS, which is sensitive to a variety of the criminal thinking errors that I went over. But you really, like with any assessment, you have to determine, what can you use, right? Like, what is your budget? What is your time limit? What population are you working with? Are they able to sit down and do an 80-item questionnaire, which is what the PICT says? So I think the reason for us, we're using the measure of offender thinking style is because it's public domain. And the question allotment is one that we have been able to actually execute with our patients. One that I'm sure people in this audience have experience with, but I personally don't, is the LSCMI, which came out of the LSIR, which really does look at all of those kind of criminogenic needs. And the beautiful thing about that is that it doesn't just look at the risk factors, but it also looks at protective factors. It's strength-based, and it can make recommendations, for how you can, kind of create more of a balance, so that those protective factors, are weighed or counterbalanced with protective factors. And it does address antisocial cognition. So I need a drink of water because I've been talking so much. We have like 5 minutes left, and I do have people in the audience who are currently running a group utilizing the interventions and framework that I talked about. So I was hoping that we can use some of that time just to hear them and hear about their experience providing this intervention within the state psychiatric hospital system.
So what I'm going to do is make those presenters panelists so that they can speak freely and turn their cameras on. While I'm doing that, I just wanted to let you know, Dr. Morfe, if you could give the control back to Dawn. And also there was a quick question that came in, if you wouldn't mind answering while I'm making everyone panelists. Can you elaborate on what the interactive journaling part looks like?
Sure.
Thank you.
So again, at the end of the slide deck, you'll see, or you can just Google change companies. Their concept is they make a lot of these beautiful workbooks, and their model, the reason why they create these workbooks is because of the concept of interactive journaling and this belief that through repetition and mastery, that people are more likely to be able to learn and then utilize the concepts within the workbook, sorry. And I can say in our experience, my experience doing this in the prison system, and also my experience working in the psychiatric hospital system, is that people really like the workbook. It's very eye-catching. I think that it helps people feel like they're working on something. You can also, reflect and look at, maybe how far you've come or all the progress you've made over the course of your group. So I think it's a really nice addition to the group. Another thing that we'll do is also, make our own handouts about the various criminal thinking errors, so that between sessions people have some kind of dictionary of sorts, so that they know what kind of thought process they're trying to really focus on or be aware of any given week.
Okay, you're all set. Leah and Sherry are now panelists.
So Leah and/or Sherry, Dr. Morfe wanted you or invited you to come today to share some of your experiences and insights in facilitating such groups or individual interventions. Would you like to speak to that a little bit, or any of the points that she has made, maybe highlight, reiterate, give examples, or in any way you feel comfortable contributing? We'd love to hear from you.
Hi, sure. I haven't had experience running these groups in the state hospital system, but in federal prison system as well, as Dr. Morfe talked about. I think she really covered all of the points, everything that's really important to know about this topic. But one thing I would just want to add is that it really tends to induce a lot of defensiveness in people. And I like that she started with the question about, have you ever gone over the speed limit while driving? Because I think criminal thinking is almost a misnomer. It's really thinking that we all fall prey to, and we really need to recognize that it's more of a human element and normalize that for the people we're working with. that they're not these bad people with these bad thoughts.
Thank you. Thank you. Sherry, I see you have two individuals there. Would either one of you like to comment or to add to the discussion?
Hi, I'm Melissa. We're psych interns. Sherry and I are psych interns at here at TPH, and we're running one of the groups that Dr. Morfe is describing. We definitely agree about the workbooks. The patients seem to love the workbooks, and they're really useful for them to follow along. You normally see them like they're listening to what we're saying, but they're very like engaged with the workbooks, and it's easy for them to kind of like go back and like highlight concepts, and they really enjoy actually like reading the text and looking at the examples. So it's definitely been helpful.
And this is a question that I have for, I guess, all of you facilitating these interventions. Do the patients get to keep the workbook? Is that something that they, or a copy of it, something that they could take with them and I guess help them through their recovery moving forward as well?
Yeah, it depends on the rules of the unit, I would say. On our unit, we give them the option to be able to take them, but we remove the staples, from the outside and things like that. So you just have to take some safety precautions with the workbooks. There are some members of our group that opt to take them and read them in their own spare time. And again, like Melissa said, we kind of also will go back to the week prior and like review. So we'll constantly go back and review concepts that were previously like reviewed to kind of get them to continue to learn a new piece each week. And I think that's really been effective as well.
So that continuity piece that structured manual or workbook allows for really sounds like it supports the process and the recovery. Mm-hmm. Wonderful. Thank you.
There was one question that came in about any thoughts on adapting the material for non-readers?
I think that's a great question, and I don't see why not. I think that, the reason why there was this structure is because it does fit those kind of best practices in terms of, the principles for utilizing CBT with the forensic population. But if you're working from an R&R model, in terms of that responsivity, you always have to be agile and flexible to tailor your intervention to the people you're working with.
Well, we would have individuals in our group that like maybe have more difficult time reading, but those individuals, we wouldn't have them read from the manual, but we would have other group members read from the manual, kind of participate in that way. And then we may just like elicit conversation and provide a lot of examples, like real life examples for the individuals that are having difficulty reading the manual. This way they're able to like apply it. And that seems to help for those folks in our group. Yeah, there's a lot of like graphics and like the graphs or like models too, and that helps like better explain the concept. So like with the ABCs, it helps them that there's like arrows and stuff, and they can kind of follow the way that the relationship works. And they do look
at in one intervention I reviewed, a psychologist, he found a lot of video footage of really well-known criminals and would play that. And after teaching a certain criminal thinking error, would ask people within the audience to pick up on, the presence of such a thinking error. So, you can really get creative. There's, more than one way to apply this.
Thank you. And thank you for those additional comments and clarification. It was really helpful to have folks here in addition to Dr. Morfe who, provide this valuable service to the individuals being served in the state hospitals. So thank you very much. So with that, we're a little bit after 4 o'clock. So I want to thank Dr. Morfe for being so concise and clear and efficient with her presentation because it was a lot of material. So thank you very much. There is a list of references at the back of the PowerPoint, which as Jen noted in the chat, there will be a link to a survey for this presentation. Once you go to that link, there will also be all of the additional resources that were discussed in this presentation, including the list of the additional assessments that Dr. Morfe spoke about. There's also links on this resource page here for direct access to some of the other resources that she has highlighted. For any additional questions, you can contact Dr. Morfe directly. And here is the link for the training evaluation also dropped into the chat. It's really important we hear back from all of you because we do like to know how these trainings are being received. And additionally, we are also, soliciting additional speakers. So if you or anybody that you know has relative expertise in an area that is important in the state psychiatric hospitals that you would like to share with your peers and with those who are working in conjunction with you within this setting, please feel free to reach out to us at Rutgers SHPRI. And I think Jen is going to drop the link, if she did not already, into the chat.
I just did.
Okay, thank you. Thank you. To identify if there are any other individuals who are interested in presenting. So with that being said, I want to thank Dr. Morfe again, her volunteer co-presenters who joined. It's great to hear from them as well. And it's great to see psychology interns, participating in an event like that, like this. It's really exciting. So thank you for sharing your experience and knowledge as well. And we're going to go ahead and wrap up. So thank you, everyone. And please be on the lookout for your additional or upcoming webinars that we'll be bringing you. Thank you.
Thank you.